Great. Thank you so much for the invitation from both SAPC and ASME to come and talk to you today. I'm going to dive straight in and say that I've spent 20 years studying the expertise of medical generalism. So I'm going to talk today about what generalism means today, starting, if I can get this slide to work, with this, the report from Health Education England declaring that the future doctor is a generalist. I was curious to see this report come out, having spent 20 years looking at it already. But I was encouraged by their words that the report recognises that the applied wisdom of the generalists to make complex clinical judgments as independent thinkers in order to manage uncertainty and risk. These are the skills of scholarship that we talk about in the WISE GP programme. But I was uncomfortable with a recognition in the report, of this description in the report of how we compare generalists and specialists. So this idea of the generalist being about a breadth of skills and the specialist about depth. And really this diagram for me perpetuates a long-standing myth about generalism, that generalism is about being a jack of all trades, with the implied but often unspoken master of none. Generalists know a little bit about a lot of things. And if you think that's what a generalist is, then the solution to having more generalist practice becomes about knowing more stuff and using digital technology and more people in order to be able to deliver more knowledge in context. But actually, it was this editorial in the New England Journal of Medicine, of all places, in 2017 that reminds us that that's maybe not what we should be thinking. Wenzel described that in modern medical practice, it's not what you know, but how you use what you know that matters to get results, to get good practice. And that takes us to the idea of thinking about how do we know things? What is our knowledge that we use in practice? Knowledge, if knowledge is our justified beliefs for practice, how do we do that? Well, obviously the dominant model at the moment that we're taught and that we design into health systems is the idea of evidence-based medicine. Evidence-based medicine teaches us to find and critique knowledge for practice. But it recognizes a hierarchy of knowledge for practice that defines the best knowledge, the best evidence, as that's derived from externally created knowledge, objectively created knowledge, ideally in randomized trials, experimental studies, and metasynthesis. Evidence-based medicine shows us how to find that knowledge, how to critique it, and then it asks us to use our clinical judgment to decide whether we're going to apply it to the patient in front of us. But it doesn't tell us very much about how to do that. And it certainly doesn't make a differentiation between clinical judgment and the expert opinion that comes at the bottom of the hierarchy there. But evidence-based medicine doesn't also reflect the realities of how we use knowledge in practice that goes on in expert generalist practice and in whole person medicine, that is primary care general practice. And for this, we go to the work of John Gabay, which pulls together a whole body of research and scholarship from before, but really talks about the way that clinicians use knowledge in practice is a complex iterative process of socialization, externalization, contextualization, and then internalization to create new knowledge in practice in context. If knowledge is our justified belief for practice, then what John Gabay's work and his work on practice-based evidence talks about is that knowledge comes from our internal process of the knowledge work we do. The knowledge work we do to explore, to explain, and to evaluate the phenomena that we see in practice, whether that's an ill patient in front of us or a practice-based problem. But my research over a number of years has shown consistently shown that there are a number of barriers to clinicians, to doctors using this approach in clinical practice. And we summarize this as the 4 Ps: Clinicians describe that they feel that they lack the permission to step outside of the evidence-based medicine guideline and hierarchy. They lack the professional skills and confidence to do it in practice. This work isn't prioritized within their work set. They used to describe they didn't have the time to do it. They now describe they haven't got the headspace to do it. And they lack the performance management that supports this model of work and enables them to continue. But if you look at some of the key policy documents that are coming out at the moment, whether you look at Ridge on over-prescribing or the fuller stock take, the King's Fund reports, the concept of minimally destructive medicine, all of them are talking about we need a culture shift in medical practice. We need to shift away from focusing on disease and just applying the guidelines to how do we do whole person care. And that's why from the WISE GP work that I lead, we're recognizing the missing piece that everybody's calling for in the culture shift that we need is about focusing on the knowledge work of everyday clinical practice. And that's the focus for the work that I do at the Academy of Primary Care at Holyoke Medical School. We aim to use innovative scholarship to drive excellence in primary care, but it's the emphasis on innovation that's a particular part of what we're doing. And I want to use two examples from our work to just introduce some of that, take a little bit more detail on some of that to you today. One is a workforce-focused piece of work on, called Catalyst, and then I'm going to have a look at a more work practice and work-based place piece of work into the Times project. So Catalyst is a NHS England funded piece of work. It was a pilot project for the new to practice GP fellowship scheme that some of you may be aware of in the UK. And NHS England Yorkshire came to us at the Academy along with our NHS GP partners and said, what can we do with this fellowship scheme to try and address some of the challenges we're facing in practice at the moment? We have a problem with recruitment and retention, and we have a problem with the skills and confidence of our workforce to deal with the complex problems they're seeing in everyday practice. So we started with the 4 P barriers, if you like, and we thought, okay, what can we do to try and overcome some of those barriers, and how do we design that into a fellowship program? And this is what we came up with. And some of you will have already heard some of this in the previous session. But essentially, the goals of the Catalyst program are to help the new to practice GPs to develop a different understanding of their professional role, tackling those barriers of permission and prioritization. What are the elements of your job you should be doing? We wanted to help those GPs to develop the extended skills of professional practice that looks at that SECI cycle on the John Gabay side of the slide, rather than just the evidence-based medicine they've been taught so far. And we wanted to help them think about thinking about their lifetime of professional practice. How would they know what they were doing was doing a good thing? How would they know whether they were doing it well and continue it on? So we drew on the evidence that had accumulated through the work I'd previously done to come up with a logic model, a complex intervention that describes what this workplace educational intervention was going to be. The model is delivered through effectively 11 modules in the first year, which help the new to practice GPs to develop understanding of the knowledge work for clinical problems, but also of beyond clinical problems into practice problems and quality improvement issues. And we have an embedded evaluation in the project informed by normalization process theory that we'll come to now. So some of you have heard Dr. Delolio present this work in the previous session, but I'm delighted to be reporting that already her evaluation is showing that the impact of the program is starting to make a difference in each of those barriers. So we're seeing a sense of people having a different sense of what their job is about, the meaning of their job, of developing skills in working beyond protocol, beyond guideline care, but actually into that knowledge creation and critique setting. They're starting to develop a new sense of what their job's about and what that means in terms of how they'll be able to monitor their impact as they go forward. And they're starting to challenge the 10-minute consultation model and recognize that actually we need to redesign practice if we're going to do this. The bit I certainly had under-anticipated from this work, and I think all of us to a certain extent, is we're also seeing how much this work is changing our communities of practice. It's creating a really important community for the new to practice GPs, but it's also bringing the tutors of the programme into that community. And then our extended wider NHS partners as well. So from one complex educational intervention, what we're developing is a new thinking right the way across our general practice community in Humber Coast and Vale about what the job is and why it matters and how we do it and how we design things to help for that. To the extent that our partners have now both extended and expanded our funding, so the project is now moving on from pilot into at least another 2 years with an intention for a rolling programme. And perhaps the biggest thing I can offer as an example of the impact of the programme is a blog written by one of the delegates on our programme, and I've put the link there so you can have a read afterwards. So this is an example of taking an intervention that's changing the way we think about and do knowledge work in practice, that we're already impacting on the workforce motivation, on workforce practice, and also the workforce community. So I'm going to move on to a second example that focuses more on that workplace setting. Starting with this piece of work, which was actually done 6 or 7 years ago now, when I was working down in the Midlands, where we were doing an evaluation of how a new way of working that had been introduced into practice was working on the ground. So this was a frailty initiative. It was an evidence-based model of care to support patients who were recognised as having frailty. It was a toolkit, if you like. The evidence says, do this, do this, do this. It's handed to the practices in a box, in a toolkit box, along with a contract that enabled them to employ staff to do it, pay the staff to do it, and a set of boxes to tick to show they've done the work. So a very sort of traditional idea of how we put knowledge into practice, if you like. And we used normalization process theory again to focus in on what was the work that was happening on the ground. They wanted an evaluation of the project to show that it was reducing admissions to hospital. And what we did was actually go and have a look, how were the practices doing this on the ground? And you're not going to be surprised, given what I'm talking about here, that our evaluation showed that actually it wasn't happening successfully on the ground, but it also told us why it wasn't happening successfully on the ground. So what we saw were that practices were having to spend a lot of time on the knowledge work to reshape this toolkit they've been given, to refashion it so it actually worked for them in context, to take it through that SECI cycle, if you like, to say, okay, that's the evidence done objectively externally, but if I want to know what the knowledge is I'm going to use internally, what needs to change? And what was clear from the evaluation is that the staff didn't have the resources to do that. And by that, I mean the people, but also the skills and the confidence within the staff to do it. And the contract wasn't set up to support it either, because the contract was just measuring how many patients had you seen. It wasn't allowing for all of the setup implementation work that had to go on first. So what our evaluation showed was that successful implementation, if you like, needs flexibility and adaptability so that we can adapt the evidence on the ground, take it through that cycle. And that needs expertise as well as evidence. It's not just about taking a piece of work and plonking it in. We have to recognize the knowledge work that goes on the ground to make this happen. So we really need to think more about how we support what we often talk about as translation of knowledge, but it's into the idea of practice-based evidence. How do we develop, how do we create, act on, and then critique the practice-based knowledge and evidence on the ground? So that piece of work informed the thinking for a research bid that went in, and we're just finishing off and should be published hopefully in the next couple of weeks. This was a health technologist assessment, HTA, whichever it stands for, bid looking at deprescribing. So it's a realist review of the evidence on deprescribing for patients living with multimorbidity. And again, that piece of work really focused on what are the elements needed in place to support the knowledge work that goes on. HTA wanted us to produce a thing that said, if a patient's on this drug, stop it, and this is the effect size you will see. The data doesn't support that. What it does support is the knowledge work that's going on the ground, and to make that happen in practice, you need data, but contextual data, not just data on disease. You need explanation, you need trust, and you need a supportive infrastructure. So we've got 4 elements for a complex intervention, if you like, for how to do the knowledge work for generalist care on the ground. And we're now taking that work into a new program grant, which has just started, which is looking at the issue about how do you support tailored management of sleep for people living with dementia. But what we're doing with this is we're bringing in these knowledge work elements right from the start and designing them into, co-designing them into the complex intervention from the start. So you're not surprised that I'm saying today's generalist doctor and clinician needs the knowledge work support for the complexity of the job we do, whether that's working with a patient or whether it's working with practice level problems. And that's what we recognized this gap a number of years ago, and that's what we spent the last 5 years working on in setting up Wise GP. The idea of Wise GP is to help raise the profile of the idea of the knowledge work of skills, the knowledge work of practice, and to provide resources to help people do that. So if you go to our website, if you talk with us, then we have a number of resources on there, including the stories of knowledge work. So you can see examples of people and the knowledge work they do for themselves, as well as the practice-based stories of knowledge work making a difference. We've got learning resources on there, including a new online learning tool, the Wisdom Project, in which you can learn applied knowledge work skills. And we're building community on that resource as well. So getting in touch with people through that. And we would suggest that this is at least one of the elements. The Fuller Stocktake recently about the future of general practice said we need to create the culture for change. Well, we're recognizing this as being certainly a contributory factor to that. So we're hoping to take that back to Fuller and suggest that they do. But here I am in a room full of knowledge work experts and a virtual room of knowledge work experts, wherever the cameras are, to our colleagues in ASME. So I just wanted to draw this together by thinking about what are the implications for us as an academic community. And I think there are 3. I would suggest that if we're going to contribute to building, sustaining, and making and creating the impact of how knowledge work is going to be part of making the culture shift that the NHS is calling for, then we need to ask ourselves about these 3 elements. First of all, that we need stronger integrated scholarship. And by that, I mean bringing research and education together. So our university organizational contexts have often split us apart. This meeting is brilliant because it's bringing us back together. It's always been part of SAPC, and it's fabulous to be able to work with ASME and our education colleagues as well. But the work I've been describing has not been about research or education. It's been about both and working together. And I think that's a crucial part of us as continuing to have an impact as an academic discipline going forward. The second element I would say is that we need embedded scholarship. That this is not about having small elite centres doing little bits of high-end generation of knowledge, but actually we need the knowledge work expertise throughout the primary care community that we're supporting. And again, that's a challenge to our university models and to the academic models. But I think it's absolutely fundamental if we are going to deliver to Fuller and the NHS the goals they're looking for. And thirdly, I think we need to think about expert scholarship. So as a group of scholars, we are constantly performance managed and judged on the outputs we produce, whether the paper or the number of students we've got or the pass rates for whatever. But how often are we recognised for and supported for the expertise, the skills that we have? So we've become so focused on measuring outputs and outcomes, we forget to focus on the importance of process, if you like, and the expertise that's in there. So I think we need to re-embrace the Boyer and SAPC's description of scholarship as those 4 elements of discovery, integration, application, and learning or inspiration. I have been accused over time of perhaps being, so people think I'm trying to dumb down some elements of research and scholarship, but I'm absolutely not. And I don't know what I've done to the final slide, which has disappeared. But what I am doing here is I'm calling for us not to lower any measure. I'm still calling for the absolute highest standard of excellence in research and education. But I'm also calling on us all to become trailblazers. We're not pleading special case for primary care. We are trailblazing both the needs for primary care, but also how we can be a new model for academic practice going forward, wider than primary care and general practice as well. So if you're a trailblazer, I would love to hear from you. And if my final slide was there, you'd have my email address, but hopefully it's in the program book as well, so you can have a look at it there. So thank you very much.
So much, Joanne. Umesh has got the questions.
Well, I'll say morning again because I'm not quite sure how the ether works in terms of translating what I am and who I am. So for those who don't know, I am Umesh Chauhan. I'm the Professor of Primary Care, UCLan, and Chair and host. So welcome. I do have one question and it's from Catherine Harvey, and it's thank you to start with. Interesting talk. Do you think a rebrand of GP is needed to help highlight our generalist skills? For example, a name change to consultant general practitioner.
Thanks, Umesh, and thanks, Catherine. So the Catalyst programme, our Catalyst delegates is what they call themselves. Our Catalyst delegates have decided that one of the things they're going to do to reward themselves at the end of the year is create themselves a big badge that says, I am a consultant in primary care medicine. So they're rebranding for themselves on the basis of the discussions of what's going on here. They're seeing their job differently. I'm not going to declare what I think a brand needs to be. And I think it's more about how we market, if you like, the brand that we have. So general practice, general practitioners, for example, and needs to be recognised as consultants consultants and experts in primary care medicine, leading a team and working with a team and so on and so forth. But I think, yes, rebranding, but I think we need to do that collaboratively within the general practice community, but also then with our allied health professionals as well, because we work in teams now and have done for a long time, and it's how we think about that. But I do think professional identity for every single member of that team is also really important, because some of the work I've done, so a lot of people are being trained as generalists, if you like, but against that model of a generalist is a jack of all trades, master of none. So I do a lot of teaching with, or do some teaching with advanced clinical practitioners, with PAs and with other professions. And we start off the discussion, are you a generalist? Are you an expert generalist? And their identity is that they are generalists, but when we talk about what I understand as the expertise of generalists, then they realize they're not being trained to do that. I'm not saying they couldn't do it, I'm just saying they're not being trained at the moment. So these issues of identity really, really matter, I think, here.
Thank you, Jo. I have a question from a chap called Rupert Payne that some of you might know. He says, Fab talk, Jo. Do you think emphasising the scholarly nature of general practice can be used to help draw new people into the profession and help address the workforce crisis?
So it's an interesting question. Thanks, Rupert. When we started off, it was the RCGP conference last week, and Wise GP started an RCGP conference in 2017, so 5 years ago, where we had a room full of doctors talking about all of these ideas, but without a shared language to talk about it. And some of them were there was a lot of antibodies about calling it something to do with academic general practice, if you like. So those of you who work in general practice will know there's still quite a lot of antagonism in some people between academic general practice and what others consider to be proper general practice. So we started then talking about scholarship, clinician scholarship. I mean, the GMC says every doctor a scholar. So we used scholarly practice or clinician scholarship as a title that at least didn't create antibodies. People didn't really know what it meant. They were confused by it, but at least they weren't anti it. And so for a while, Wise GP was talking about the scholarship of clinical practice. And then gradually over time, again, that scholarship wasn't necessarily, I mean, we know what we understand by scholarship, but again, practitioners didn't. We started to toy with this idea of talking about wise GP or wisdom, which again created antibodies for some other people I know, and probably ASME too, because obviously wisdom means something very specific in some contexts too. But interestingly, then people sort of start getting shy about, well, I'm not going to call myself a wise GP. It was really interesting to see. But gradually now, again, we're seeing that sense of pride and standing up and standing tall. So sorry, it's a long-winded answer to the question, but I think, yes, absolutely. We need something about being proud of. And the work in Catalyst certainly is showing us that this is one of the ways we can help people feel proud about general practice again.
Thanks again. I think I probably just need to stand here so people can hear. Clearly, we've got some antibodies to using this box for asking questions, because there's a lack of questions. A wise a yoga master who told me recently, this morning, that expertise equals knowledge plus practice or repetition over time. How does scholarly activity fit into that?
I think that those are two elements of it, but there's also, so if we think about it as creating, acting on, and then critiquing, then the bit that's missing for me that is the creation bit. So we assume, again, evidence-based medicine assumes that the best knowledge is created externally, objectively, and then translated in. There's a really interesting, well, I think it's interesting study a few years ago looking at Clark's, which talked about, which analysed how they were creating knowledge, if you like, with their communities, and describes that there were two forms of knowledge work, as I would say, going on. There was the traditional model of bridging, where you still have the objective researchers doing the science, and then a knowledge translation bridge to take that into the context. But also within the Clarks that are now ARCs, they were seeing a blurring model where you took the academics, the researchers into the clinical context and actually created the knowledge together. And this piece of work recognized that the knowledge created by those two different models is different, but not necessarily one better than the other, and that they both have their place in shaping a healthcare system, if you like. And the work I do is suggesting that actually we've got lots of this one going on, but it's not on its own, it's not enough. So we need some of that, more of that blurring work if we're going to achieve those culture shifts that Fuller and Ridge and Montori and May and all the others are asking for.
Joe, we've got a question from ASME. For some reason, there's been a bit of a technical failure. So Gabrielle Finn, hello, Gabby, says, totally agree. We need to move away from single disease frameworks to whole person care. While we've discussed the changes that need to happen for practitioners, what are the system changes that need to happen to accommodate this cultural shift?
Thank you for that. Many, it has to be said, but again, this is why I think you're having this conversation now, because I think the doors are at least pushable at this point because of things like Ridge, because of things like Fuller, because of the crisis that we're in. So if we go back to the 4 Ps, we need a change in our perception of what best practice is, and written into the system model. So best practice is not to give people permission to recognise whole person care as the goal. But that means that I think one of the big system changes is about prioritisation. That I'm really interested in this shift that people told us probably 10 years ago they didn't have time to do this work, and now they say they haven't got the headspace. So if you go into practices at the moment, people are talking about a shift from a 10-minute to a 15-minute consultation, or even a 20-minute consultation. Well, from my work, that's not going to solve the problem, because people, it's not just that they haven't got enough time. They've got too much stuff piled on their head to be able to do what's an incredibly complex piece of work, knowledge work that's going on here. Generalist care, whole person care are not soft skills. It's not just about relationships and good communication skills and you just need a cup of tea and a biscuit. We're talking about some of the most complex medicine that goes on in our healthcare system. And unless we redesign the health systems to recognize that and put some protected time around it, but by time, I don't just mean consultation time, I mean clearing other work off into other places. We need to think about using digital and technology differently. Stop just using it to get more and more information into the system, but actually get cleverer about the data that we use, for example.
Oh, hang on a minute. Oh, surprise. A young man called Greg Irving asks the question, can you comment on the international nature of expert medical generalism? Consultation length varies between 1 and 22 minutes around the world. Any thoughts on how the EGP varies?
Thank you, Greg. And I know you're working with Japanese colleagues on this as well. And we too are also starting to work with some Japanese colleagues on that. And also I've been having these conversations with colleagues in Australia, in Europe, and in America as well. The optimist in me says, let's design this into systems that are still building their general practice primary care systems from the beginning, if you like. So don't let them copy our old model and build from there. So that's why I'm so excited about some of the conversations I'm having with Japanese colleagues, for example, about how can we build this understanding in. But I also know that the evidence-based model is internationally very, very strong, and we're pushing against that. So we also really need to help people recognize this is not just, this is as much grounded in science, it's just a different science. And also that we're not talking about one or the other. We're talking about the yin and yang sort of symbol again as well, that we need both designed into health systems. So it feels like we've got an awful lot of work to do here to do that. So we can't, it's a bit cheeky setting ourselves up as, if you like, experts leading others. So there's also that opportunity for mutual learning, isn't there? And that's what inspires me so much about the conversations with Japanese colleagues, because we're learning together.